So our second speaker this afternoon is Stefania Bastianello from Italy. And following the same theme, Stefania is going to be talking about early specialist palliative care support.
Thank you for this invitation and opportunity, and sorry in advance for my English. My speech, we talk about early specialty palliative care support. I start from my experience because in 1993, Cesare Scoccimarro, my husband, 32 years old, becomes ill with ALS. In June 1998, he has acute respiratory failure and he chooses for tracheostomy and PEG. So, for 14 years, he has a tracheostomy and mechanical ventilation 24 hours, no breathing autonomy, total motor paralysis, total lack of verbal communication. Cesare is able only to move his eyes, but he could not use an aid tracking because of a nystagmus, enteral feeding via PEG. But not only ALS, comorbidity. In December 2010, I turned on palliative care for two reasons. Cesare complains postural discomfort on his right buttock. It requires a continuous operation of lifting and lowering down of the entire right side of his body for periods longer than 30 minutes. This happens several times a day, and this is very difficult and is likely to affect the balance of a physical and mental health of care team because Cesare is assisted by 5 people. It also affects the psycho-emotional balance of Cesare himself. And a behavior disorder, presence of a psycho-emotional distress characterized by attitude obsessive, compulsive, and prolonged wakefulness. But hereinafter appeared, after 3 months, a diabetes type 2 insulin resistant. When taking insulin, he started from a baseline, for example, of 250, and he reached 400 or more with an evident rebound effect. After 1 year, the hepatic steatosis, after 1 year, bilateral hearing loss. After 15 months, neoplasm skin of the scalp in periauricular bilateral areas with cutaneous candidiasis and scaling. Then a respiratory distress and a genital candida. Well, I think this is a clear picture of the complexity and fragility. I work in the listening center of ISLA in Italy, and I had 1,500 contacts, and I know 550 patients. I believe there is a lack of integration between the multidisciplinary specialist team and the palliative care team. In ISLA and the Neuromuscular Omnicenter in Milan, we promoted last year a study on behavior disorder. Clinical experience has shown an increase of behavioral and mood symptoms, especially in the areas of aggressiveness, sexuality, and obsessiveness during the late stages of ALS. We studied 10 patients with ALS in the late stages, tracheostomized for 36 months, and their caregiving, using a questionnaire specifically elaborated for patients' communication limits, of course. Data showed a trend of aggression and high level of obsessiveness in ALS patients associated with several clinical characteristics. High level of anxiety emerged in both patients and caregivers. In conclusion, the study showed a potential and considerable effect of the long duration of ALS on patient personality and caregiver distress. During the work of the neuromuscular disease group at Ministry of Health in Italy, we asked to over 300 families who actually manages the care network. Specialist physician so-and-so, family physician seems to be hidden. All burden is of the family or nobody cares, and this is very worrying. So the patient and family need a multidimensional response to needs expressed and unspoken needs in terms of information, sharing, health needs, social needs, affective and relational needs, spiritual needs, and economic needs. So we have to provide an adaptive response to the needs because the need is dynamic and rapidly changing in ALS, and the answer cannot be the same for every patient, but it has to be customized. So critical issues about assistance are inadequate communication of the diagnosis and information about the disease, lack of counseling on tracheostomy, lack of qualified home care, poor control over the quality of care, difficulty to manage the patient in the hospital, limited presence of family physician, we see, insufficient local services, lack of expertise and knowledge of the operators, complex emergency management, lack about competence of mobility and communication aids, transport, and lack of counseling, especially at home. So in most cases, we can say there is no real pickup and the burden of care rests entirely on the family. So since 2011, we promoted a training roadmap in Italy on palliative care in ALS. The courses were sessions of 2 or 3 days in 12 cities. Over 30 teachers were involved, and over 300 students attended the courses. You can find here the composition of teacher, pneumologist, neurologist, physiatrist, nutritionist, psychologist, bioethicist, and of course, palliative care specialist. Here you can find the composition of professional areas of students. The most important areas were physician, nurse, and physiotherapist, then psychologist, speech therapist, other health work. Their mean age was 42 years in a range 24-66, male 31% and female 69%. What is interesting is their experience in palliative care. Only 25% had an experience and 75% no experience. The objectives were making an interactive model between teacher and students, identify specific training needs of professionals involved in the care and treatment of ALS at different stages of evolution, analysis and discussion of clinical cases, structuring a training process to identify aspects of care, organizational and care settings. Each student made 2 questionnaires. I'll show you some of the most interesting questions and answers. We asked, what is the percentage of bulbar onset ALS diagnosis? You can see only 37% gave the correct answer. Then we asked, what is the average time to disease of a patient suffering from ALS before it happens, acute respiratory failure? You can see over 55% gave the wrong answer. Then we asked, what is the mood prevailing in patients with ALS in advanced stage? Over 50% believe that ALS is associated with depression. Perhaps operators tend to overlap the oncology palliative approach with that on ALS. In fact, ALS patients rarely have a severe depression. Then we asked, do you think that taking care of the patient with ALS in the field of palliative care should be linked to the presence of motor deficits? 40% says always, even if the initial. What is the level of knowledge found in patients with ALS and their families of the content of the approach of palliative care? 42% say it is absent, So family and patient don't know what is palliative care approach in ALS. Then we asked what bias exists in the neurological center of reference about palliative care approach. End-of-life care, 57%. And then we asked what sense of helplessness do you feel when assisting a patient with ALS? The difficulty to dialectical, the difficulty to the emotional interaction, the difficulty to the proximity touch, the difficulty to relation, but they say also they have no experience, they have a lack of knowledge, they have fear. So the needs identified by Italian learners are better knowledge of the stages of the disease, a search for the role of palliative care in the early stages, the need for structured levels of care in palliative care services, overcome the culture of palliative care aimed only at the end of life, better training in palliative care for ALS, the demand for integration between specialist team and palliative care team, support for the stabilizing emotional and psychological aspects, and the need to study ethics. New year, we are designing new courses of study, implementing practical training session, because I think that in today's incurable and highly complex disease, are cross-modulated at different stage of the disease, I mean not only at the end of life, approach may be the way to cure when you cannot heal. Cesare died on 26 July of this year. He taught me a lot about ALS and encouraged me in the path about palliative care in ALS. So, thank you, Cesare.
Thank you, Stefania. Okay, do we have questions? Don't all rush at once. I see no hands. No?
One question.
Okay, we've one here.
Speak slow, please.
Just to say thank you very much for that very moving presentation. I think I speak for everybody here in saying how moving it was and how much it's taught us. Thank you.
Thank you, Stefania. Thank you.